Well, good afternoon, and welcome to the Woodrow Wilson International Center for Scholars. My name is Kaylin Ostrowski, and I am a program associate here at the Wilson Center's Global Health Initiative and Environmental Change and Security program. And I want to extend a warm welcome to all of you and to our distinguished panelists. And thank you for coming to today's discussion on accessing maternal health care services in urban slums. What do we know? As coordinator of the Center's Maternal Health Dialogue Series, I would like to extend a special welcome to our guest from the African Population Health Research Center, who joins us today as we kick off our formal partnership together, in which we will collaborate and co-host 2 dialogue sessions in country on neglected maternal health topics. Enacted in Congress in 1968, the Woodrow Wilson Center is a living memorial to our 28th president, who was the only president to have a PhD and was a strong advocate of uniting the world of scholarship with the world of policy. And for those of you who are not familiar with the African Population Health Research Center, they are headquartered in Nairobi, Kenya, and they bring together African scholars, journalists, policymakers, and other agents of change to improve health policies and programming in sub-Saharan Africa. And it is within this convening spirit that we are very excited and delighted to be partnering with the African Population Health Research Center. By combining our collective convening power, we will head to the front lines where maternal mortality rates are highest and work directly with local, regional, and national changemakers to improve maternal health in the field. Although we host these meetings in Nairobi, we are very excited to announce that all of you will be able to participate in these meetings through live video conference that will enable you to directly participate in these live discussions in Nairobi. Additional details about the in-country meetings and simultaneous Wilson Center events will be available on our website, so please stay tuned. And in addition to collaborating with the African Population Health Research Center, we are grateful for the support of our co-conveners, the Maternal Health Task Force, UNFPA, as well as technical assistance from USAID. So before I turn the floor over, a couple of quick housekeeping things. We are webcasting this event live, so what that means for all of you here in the room is during the Q&A, please wait for a colleague of mine to bring you a mic and announce your affiliation and name. For those of you watching at home, the PowerPoints are available online, and if you have questions for the panelists, please submit them to our Global Health email, which is just globalhealth@wilsoncenter.org, and we will do our best to have those questions answered during the Q&A. So now, without further ado, I'm going to turn the floor over to John Townsend, who is going to chair today's discussion. John is the Vice President and Director of Population Council's Reproductive Health Program. He is responsible for overseeing the Council's contraceptive product development, as well as the design and implementation of strategies to promote better reproductive health, family planning programs worldwide, especially among disadvantaged populations in developing countries through research and policy innovations. Again, a very warm welcome to today's discussion on accessing maternal health services in urban slums. What do we know? And thank you for coming.
Thank you very much, and I'd like to add my welcome to this panel in the Maternal Health Policy Dialogue Series. We have 3 great panelists today, and I'd like to introduce them and then give a few comments to kind of frame the discussion. Our first presenter will be Tony Kolb, who's our Urban Health Advisor at USAID. Tony will talk about challenges of tracking health indicators in urban slums, and how slum mapping can be utilized to improve health. And you'll see why that's an important issue as we move forward. The second presenter will be Catherine Chaptungi, who is Director of Health Systems and Challenges at the APHRC in Nairobi. And she'll be talking about the status of maternal health in Nairobi's informal settlements and share lessons learned and translating research into policy action, how that actually works, which is an important element and follows directly on the conceptual presentation, I think, that Tony's going to be setting up. The last presentation is going to be by Luc Debernis, who's a Senior Advisor on Maternal Health in Africa at UNFPA. I don't know if I could say really in New York because he's on the road most of the time. And he will be discussing sexual and reproductive health interventions used to improve maternal mortality rates in informal settings. Before we start, I think I should mention kind of three trends or elements that should be mentioned before we approach this topic. The first one is the general topic about urbanization, since we're talking about assessing maternal health services in urban slums. There are some larger contexts in which this is occurring, and the first is urbanization. Globally, about half the people in the world now live in some sort of urban setting. It'll be 60% or over 60% by 2030. Africa and Asia will slowly move up to that point, about 50% by 2030. And what is characterized as urban is really quite diverse. We think about big cities in Latin America and some in Asia, for example. But some of these cities over 1 million, actually the major, I think it was Lucknow, one of the major sales elements were farm implements. So it isn't the typical urban setting. They're selling plowshares and seed grain, as well as steel in some of these secondary cities with very large populations. Clearly, urbanization is going to be an issue, both because of in-migration, which varies from 3 to 10%, per year, big migration into urban areas, depending on civil conflicts, as well as natural migration in search of employment and other opportunities, as well as the natural increase. It seems that while urban areas in general have somewhat of a slower or a lower birth rate than those in rural areas, as you get large rural populations coming to urban areas, you see somewhat of a different picture, and particularly in the slums, that's true. To date, at least, we've seen a general link between urbanization and poverty reduction. Whether that remains to be seen in urban slums, it's difficult to see. Many of the data are not disaggregated, and as we look closer at urban slums, I think we'll learn a great deal more. The second point has to do with kind of services, maternal health services in urban area. Health systems in urban areas are highly differentiated in what could be termed as loosely differentiated areas. Many of the urban areas are slums, and so they aren't well mapped, they aren't well described. Although informally, I think we'll see mapping techniques allow us to make explicit some of these things. They're highly differentiated in terms of their public services available, private, mixed. Some are qualified providers, and there are many quacks and so on. So a health system is quite diverse, including pharmacies, insurance schemes, vouchers, and others. A common theme in reproductive health is, of course, inequalities. In terms of inequalities in urban services, we see both huge types of contextual differences as well as communalities. In principle, the density of services does not mean that people have greater access. Due to fees, requirements for accessing certain insurance schemes, as well as plain discrimination and stigma against poor or groups of certain ethnic minorities, urban services, while they may be present, aren't necessarily accessible to people. We have two types of exclusion. One is massive exclusion, as in the case of Ethiopia, for example, where no one in rural areas has care from a formal health system, and in urban areas, the poorest have relatively little access. And the second type is marginalization, where you get poor access and quality of care for the poorest people, and the wealthiest have the best services both in rural and urban care, and rural and urban areas. That's similar to Ghana. In some ways, we need to, when we're talking about these things, we need to map them and describe them in the context so we can think about what we do about them. Thirdly is, while we focus on, I think, maternal and newborn services, and that's entirely relevant given our focus on MDGs, we might be better served if we look at this data and interpret it in terms of the larger strategies of improving women's health, not just maternal health, and thinking also as the role of women in health. Health services depend on human resources, and thinking about the role of women in health and how we produce that, promote that, reward that is probably critical for the way we think about moving forward. Julio Frank, who's been a presenter here, is often one to repeat that. He's the dean at the Harvard School of Public Health. He's often repeats that about a critical way of thinking about these issues, not so vertically, but in a way that he describes as diagonally, moving forward our agenda while we think about multiple benefits. Clearly, this has implications for what we talk about. both maternal morbidities, which are relatively less talked about, but also sexual violence, STIs, and other issues that may be emerging in the next 20 years, including cancers for women. I would hope that this session would help us not only to understand what's going on, but help us to move more quickly from what we know to what we can do about it. So I think with that introduction, let's start with Tony. Tony, the table's yours.
Thank you, John.
We'll have about 20 minutes, and then questions and comments for clarification, and then at the end we'll have a more general discussion.
All right. I think Luke said he was going to speak for less than 20, so I'm going to eat some of his time if the speaker will yield.
You can see it somewhere.
Well, thank you. Thank you to the Wilson Center for the invitation to speak. We have good collaborators over here and good supporters, especially on the urban front, and I'd like to recognize that. The last time I was speaking in front of a webinar audience was, I think, in 2007. There was the UN FPA report, State of the World's Population, that year. I'm trying to think. Here it is.
2007?
Yeah, 2007. It was Unleashing the Potential of Urban Growth. I was here speaking with the author, George Martin, of that report about urban health. So that was my first opportunity. And actually, I'm going to repeat a couple of the slides, but I will try to stay true to the questions that were asked of me. But first of all, I have to come clean. As you can see from this photo, Catherine and I have known each other for a few years. And, well, the question is, do I look uncomfortable in that photo, or do I look uncomfortable standing here today? It's a little bit of both. I'm actually an engineer, but I could probably call myself a public health engineer. But particularly when we talk about maternal health issues, it's a little bit out of my normal area of comfort and focus. And I have to back up and explain a little bit about why I'm standing here and why I'm working with AID and the situation that led to the creation of the position that I fill. Within USAID, there's a fairly long tradition of urban programming, which is a bit slum-orientated, a bit focused on housing and the conditions that people live in poor urban settings. And there's also some history of collaboration on our environmental health interventions, where I think it's fairly obvious for anybody that's been to a slum in a developing country, the two are sort of natural partners. Sanitation, conditions of the environment in which people live are obvious considerations related to health. So there has been a historical collaboration between those two very different technical areas of the agency. And I actually sit between those now. Half of my position is supported by our Global Health Bureau on the environmental health side, which is now part of our maternal child health division. And I also sit in the urban programs team, which is in our EGAT, which is the sort of General Economic Growth, Agriculture and Trade Bureau. But the other part of my discomfort is that as a result of this sort of environmental linkage, the focus really has more been on child survival and child health rather than maternal health. Because of the importance of diarrheal disease in child survival, that is really the area of strong focus. And I've spent a lot of my time in the last few years working in the agency on water and sanitation among urban populations, in addition to some of the more traditional child survival types programs that focus on other areas of healthcare, but focus a bit more on the community elements, which I think with maternal health, certainly there are community-based interventions that are of focus, but there's always a facility orientation as well in the way that we look at skilled birth attendants and the issues of complications and the need to go to facilities when we focus on mortality in particular and with maternal mortality. So I'm stretching a little bit here, but I'm really happy for this opportunity because it's an important stretch, because I need to continually find connections to our existing programs and work, especially in our current emphasis on integration across programs. Because as John was saying, the problems of the urban poor are highly integrated. And to address one aspect of them, you really miss a lot of opportunities in the others, or you ignore the complexity of the challenges that poor people face. So I'm happy to reach today, and hopefully I'll be more comfortable by the end of the discussion. My assignment, the questions that were asked of me, were to talk about the challenges in working with health indicators from an urban setting, and to talk a little bit about slum mapping. Mapping is something I touched on in my last presentation, and an area that has been part of urban health programming in a number of countries, and a particular contribution of USAID in a number of countries. So we'll talk a little bit about that. But I wanted to back up a little bit and first address and explain a little bit of my orientation in my presentation here, is that these questions somewhat assume that we are all in agreement that urban populations are important for achieving maternal health goals that we've set for ourselves. And I would say that is not a fully agreed question in many people's minds. And my constant challenge among my health colleagues is to try to convince them otherwise, that for both child, maternal, and a number of other areas of health concern, focusing on urban populations is very important if we're to achieve our goals in global development moving forward, especially moving forward, as it being, as John was mentioning, an emerging area of concern because of the demographic trends that are going on. But let me try to begin to answer that first question. The challenges that I see are, again, a bit, Catherine would know very much about the challenges of sort of collecting the data, the day-to-day challenges of sending enumerators out to the field and trying to track urban households that many of the women are involved in productive activities outside the house, and just finding them at home is oftentimes very difficult, much more so than in a rural setting where their work tends to be a bit more around the house, and at least you can find out where they are because somebody will tell them, well, she's over in that field over there. But what I refer to as some of my concerns and issues with the data as presented when it's presented to policymakers of different kinds, the sort of discussions that I get involved with. And a concern that I cannot quantify, but I just raise and hope to try to highlight and eventually to get some attention towards, is that I believe that there is a sample frame problem. In the way our main source of data is from our USAID-supported DHS surveys. The DHS typically goes into a country, sort of deals with the census data or other information on the population as it exists as sort of a given. There's not a lot of questioning that goes on about that as a basis for their sampling. And with the dynamics involved in urban poverty, I think one would, suspect and be probably justified if one was able to really dig into it, that there's a systematic bias in the way that the urban poor are counted. Informality is sort of what one of the defining qualities of slums is associated with official record keeping. People don't exist on the books, aren't registered typically, and oftentimes are not counted in a systematic way in many cities, especially the larger ones. So I would say that because we're typically going in and sort of accepting as true the way the government describes how its population is distributed, that we're going to systematically sort of undercount the urban poor. And so I say that is sort of a challenge in trying to come to understand what that bias is and correct for it in some way. The other major problem is just the term slum to begin with. You see, both of my questions and John's introductions were talking about slums. I'll go a little bit into why I don't really like that term so much, and it causes some problems. The other areas is looking at interpreting the data. And I think the most important one is that too often wealth indicators, inequality indicators are sort of ignored in the way data is presented. Up until recently, the DHS would typically present urban-rural averages. And I think it's pretty well understood that cities tend to have more wealthy people than rural areas, so you have an immediate bias there in sort of taking the average of an urban population, and you sort of ignore those parts of the populations that you'd likely to be paying attention to with health interventions, which is the poor and vulnerable populations. And then there's a bit of a lack of attention, I think, to the diversity in urban realities between countries and between cities. Cities are different sizes, as John was mentioned. There's small towns and big cities, and understanding that those economies and the dynamics of the social activities in those different types of places are quite different. And simply, just comparing Asia and Latin America to Africa and their the sort of trajectory of urbanization in those different continents has been quite different. And so just simply talking about rural-urban without recognizing that each country experience is quite unique, I think is ignoring and missing some important points. Getting back to the slum classification problem, though, simply put, slums have only recently been categorized in a consistent way by UN Habitat as it struggled to codify the MDG associated with slum communities. Sort of was one of those MDG indicators that was thrown in a bit of as an afterthought to improve the lives of 100 million slum dwellers. Well, then they just decided, well, we really have to come down to a well internationally accepted definition of slum. And their definition revolves largely around access to basic services, water and sanitation, and some measure of the land tenure security and housing quality of people. But especially when it comes to housing quality and land tenure, these things become a little bit hard to even standardize. But the way a lot of countries have approached defining slums and how it's affected some studies that have been done as part of DHS surveys and other work is even more sort of all out over the place. I think there's a general understanding in many Latin American countries that peripheral areas of cities are slums, are informal. Cities tend to grow too quickly to sort of catch up with infrastructure, so you get a lot of sort of ringing of informality around many cities around the world. But in Latin America, I think it's really sort of ingrained in the way people think about informal settlements. In Kenya, there's some definition based on poverty that has been used. Trying to think of some other examples. Yeah, again, it's some sense of unplanned. But the specifics of that, what that mean, really end up varying quite a bit. So this is sort of results that you find by using these definitions of slum, that in fact in Lima, Peru, slum versus non-slum, the economic profile, the welfare profile of people is quite similar between the two. There's rich people that live there, there's poor people that live in slums and non-slums. So it's not a very good way of differentiating populations, at least by welfare. In Nairobi, I think you would say that the definition that they came up with is more representative overall in slum, using slum as a proxy for welfare. But at the same time, there are poor people living outside of slum areas, and there are rich people living in slums. So it's not so like night and day, and probably is not the best word to be used. So in terms of the way I've approached this, in general, I think it's much more useful to talk about poverty, the urban poor, when you're talking about trying to focus in and identify vulnerable populations. That definitely is true in the child health world, and I think it's probably true. I mean, the relationship of welfare to maternal mortality, I think, is quite strong. So really focusing in on identifying where the poor are is a better way to talk about the problem. But when it comes to designing programs, you tend to oftentimes locate physical infrastructure or people. And there, I think, it starts to become a little bit useful to talk about slum areas or some other designation. I would suggest maybe health vulnerability zones would be a better terminology to use than the slum pejorative term. But let me get back to welfare for a minute and argue why I think it's better to really focus on welfare and describing the variations among people of different means. Well, first of all, again, I think people in maternal health as well as child health recognize the importance of finding poor people. Again, rural populations are a bit of a proxy for poverty because generally rural economies are not as developed as urban ones. But that is changing. Poverty is growing, is becoming more of an urban phenomena every day. And it is particularly in those countries where maternal and child health challenges remain. So welfare in the urban context and sort of teasing apart, looking inside the city and what urban is I would argue, extremely important. What has been more a bit of the standard approach, though, to talking about the importance of urban within these challenges is simply sort of breaking out urban versus rural. This slide, which I borrowed from a presentation that will be made fairly soon to some of our policymakers on maternal health issues, goes a little bit beyond that simple rural versus urban comparison, but here it's comparing different types of countries, low income versus high. So it's simply doing that at a different country level. And so at middle income, we see that, well, most indicators are starting to be higher and starting to be more equal in general, whereas inequality tends to still be associated with low income countries. And there's differences between rural and urban again, which is not a surprise. Everybody, I think most countries, that is the situation. But again, it's looking beyond that, a more complete story, which becomes more interesting and I think very instructive to planning at different levels. And the paper that I'm referring to, I'm going to throw up and not go through in detail a number of graphics from an excellent paper I just discovered in preparations for this talk, presented by Zoe Matthews and some colleagues in the UK, is taking DHS data from a number of countries, and here they're just using the standard measure of institutional births, and using the now somewhat standard practice of presenting data along health welfare quintiles and looking at the richest versus poorest and seeing that there is oftentimes very large gaps and large inequalities among these welfare groups. But it varies, and the level of inequality between different countries varies considerably, and then how that relates to where urban and rural populations sort of sit in relationship to another varies quite a bit as well. And they actually came up with a sort of a exclusion topology that, I misspelled topology, sorry, typology, that I think is very instructive and very interesting. And I won't go into the details here. But again, it's looking at, John I think mentioned, alluded to this, different types of exclusion, overall marginalization versus more of an inequality concern. And different countries can be sort of grouped into different aspects of that, and they refine it in some very interesting ways, which I'm going to be using. And again, I thank this opportunity that it's had to sort of look into this this issue more carefully. They represent these typologies by again, graphing inequalities between rural and urban. We have the poorest to the wealthiest. This is the urban population in Vietnam, very equitable among the poor and rich. Differences with the rural populations, more inequality there and somewhat less institutional access to delivery. So I think it's important to look at individual countries specifically and understand how inequality is different between them, how rural versus urban. Do we need to have all boats sort of floating higher? Do we need to be focusing on poor populations both in rural and urban areas critically? And also, again, look to the future in terms of the numbers behind these quintiles. Which groups, is this rural, urban, poor group in Honduras a group that's growing quickly and a population that needs to really be looked at in terms of the future for programming? Even more refined analysis, they compare cities versus towns and rural populations in Bangladesh. And again, some interesting patterns are revealed. But on to my second question, mapping. I would differentiate the utility of mapping for maternal and child health interventions sort of into two classes. First, for planning purposes. And this is a bit, I think, more of sort of the newer techniques, ones that might be less familiar or used regularly among our partners, USAID implementing partners. Because, again, if you're looking at rural populations as being your focus, generally sometimes there's differences between districts. Maybe child health concerns are more of an issue in this part of the country versus others. That sort of gross analysis, it's sometimes it's interesting to map, but it's not that interesting and maybe not that revealing or that necessary. But cities are much more interesting places from a geographer's point of view, I think, because of their high density and large heterogeneity across fairly limited space. And thus, I think for planning purposes, it's important to reveal that. And with support, I believe, from the one of the Measure DHS project, USAID Bangladesh supported a mapping effort throughout the urban areas of Bangladesh. And what's really interesting, I think, about that effort was that it I think, revealed a different way of looking about urban poverty there. Oftentimes people think of slums as being fairly large, the Kibera-type settlements, these big conglomerations, very visible ones, in terms of expressing what urban poverty is. But across the Bangladesh cities, sometimes there are larger conglomerations, but what they found is, and identified, is the vast distribution of fairly small pockets. And I think if anybody thinks a little bit more carefully about any city that they've been to in the developing world, is, oh yeah, there were those folks that are behind this wall or back along this railroad track, or filling in spaces, unused spaces. That really is a better expression overall, I think, of urban poverty. But getting a grip on that, understanding how important it is in any particular place, I think is very important for planning purposes. So why do you do this sort of mapping? I mean, you scope out the challenges. It helps you sort of get a feeling for the numbers and in scale. It helps you design interventions. Can we be really focused geographically? Are our populations geographically focused, or are they very dispersed? And we have to think of a different program approach that would reach out to them in these diverse geographic settings. And also the next layer is not only mapping what a slum or a poor urban area is, but getting in and refining a little bit more from an aerial view, the levels of vulnerability within these different pockets. And that's what they did in Bangladesh after using some remote sensing information to sort of identify these clusters. It was largely based on sort of the density of housing, roofs type, and so forth. They went in and did surveys within these clusters. And they were able to identify ones that are more vulnerable than less based on welfare, other physical conditions around the home, the number of single parent families, et cetera. Same thing has been done in the urban health work that USAID has supported in India. Again, I think priority setting is extremely important here. again, recognizing that our interventions, especially with limited resources, need to be focused at the most vulnerable people. And so getting a sense of where they are, yeah, I think is extremely important in helping to focus our interventions. I think anybody involved in HIV/AIDS programming understands that. When you're dealing with particular vulnerable groups, you have to go out and find them and map them. And the same is true for, I think, those that are most at risk from dying prematurely from childhood or maternally related diseases or issues. The next level of mapping is more, I think, traditional from many of our implementing partners activities in both in rural areas and more recently in urban. And that gets down to mapping at the household level communities themselves. And here's a picture from Agra in India, and I recently saw some work in Ethiopia where they were doing the same sort of thing with community healthcare workers. The utility of this sort of mapping is really as more of a tool for those that are given the responsibility to do community outreach and implement those community-based interventions that we feel are extremely important. I always like to end with this quote because every time I read it, it seems extremely relevant to the sort of things that I'm thinking about today, but it's actually from 1995. And highlights that there's really nothing new about this concern about poor urban populations and the importance of urbanization with health issues. But it always seems to be, oh, it's the problem of the future. And there hasn't been a lot of energy put into designing programs and interventions and a knowledge base to address these problems because, well, they're sort of in the future. But I think that really is changing. We have more and more USAID country programs that have decided that urban populations are an important part of what they should be paying attention to, and they're starting to put program money behind doing something about it. And that's where I will stop.
Thank you, Tony. Are there any 1 minute for clarifications or very specific comments? If not, thank you, Tony, for setting that up. Catherine, you're on. And you'll be talking about the context of urban poor settlements in Nairobi as a case study. Thank you.
Okay, thanks so much for being here. And it's a pleasure for me to be able to present our work. I added the last part about the Nairobi case study precisely because of some of the points that Tony raised. Because this is where we've been. We've been there for the last 9 years, and there's no question whether this is a slum or not. It's a real slum. And so I'll talk briefly about what we do as African Population and Health Research Center. And Kelleen gave a brief overview of our work. We have 3 areas of work. We do research mostly, but we also do policy engagement and communication, and then we do research capacity strengthening. And our research is divided into 4 thematic areas, and I'm heading the area on health challenges and systems. We have work on urbanization and well-being, so some of what I'll talk about borrows from that work, and then we have something on population dynamics and reproductive health, and I borrow again from that work, and then we do some work on education within the slums. So I'll talk about maternal health in the context of poor urban settlements. And I'm using some examples from some of the work we've done, but also trying to bring in an analysis we've done of the DHS, the Kenya Demographic and Health Survey data, trying to show the influence of urban poverty on possibly national indicators. So I'll briefly talk about Kenya, the country context, the urbanization experience in Kenya, and then just one slide on what the maternal health situation is like. And then try to see the magnitude of maternal ill health within these poor urban areas and beyond the numbers, and then some thoughts on possibly what can be done. Kenya is one of those countries that is doing badly in terms of MDG 5 on maternal mortality. The maternal mortality ratio as estimated from the 2008 Demographic and Health Survey has actually gone up from 418 in 2003. And I mean, the report said, because of the numbers and difficulties in measuring, the confidence intervals are the same, so there's no significant difference between 418 and 488, but you could argue that maybe it should have been 390 with the same confidence intervals, but it's not, it's 488. So there's an indication that actually the maternal mortality ratio went up, of course within statistical, it's not statistically significant, but there's an indication that the trend is not as positive as one would have expected. In terms of urbanization, Kenya is one of those countries that's, I think, experiencing an urbanization crisis. Current estimates put the urban population at between 22% and 35%, depending on which source you get your data from. The annual urbanization rate is higher than the annual population growth, around 4% compared to 2.6%. And some of the work, some of the estimates from UN Habitat put the number of people, of urban residents that live in slum or slum-like conditions at 60%. And it goes back to some of the questions that Anthony raised. Some people may not live in something that looks like a slum, but they look in slum-like conditions, and that's where they put these caveats in terms of whether they have access to water and toilets and electricity and some of these other amenities. So the estimates are around 60%. This has actually gone down. It was about 72% in 2005. So, some positive news there. And by that should be 2030, half of the population in the African region will live in urban areas. So just putting this into perspective, at this rate of, even if the proportion of urban residents that live in slums, if it stays the same, by 2030 we'll be talking about 30% of the total population in Kenya living in these kinds of conditions. If it improves, maybe goes to up to 40%, still it will be a substantial population of the whole that lives in these slum or slum-like conditions. I put this as context as well as data sources because I think I need to explain a little bit about the place where we do this demographic surveillance system and where some of this data is coming from. So the African Population and Health Research Center has been running this system since 2003, and we have about 60,000 people, give or take a couple of thousand, under like constant surveillance. And every 3 times a year we go to the same households. So we define the geographical area, and as I said, that's why it's not in question whether it's a slum or not. This is a slum by all definitions. We define the geographical area, and we identify the households within that area, and every 3 times a year we go back to the same households and ask them, the people that we left here last time, are they still here? Did somebody die? Did somebody out-migrate? And those that were not here, did somebody come into the household? Was a child born? So we monitor death, birth, and migratory movements within those same households. And by that, we're able to track not only how the slum is growing, because we started with about 60,000. Now if you take the media or end year population, it's about 65,000. So the population has actually increased a little bit. And we know how many births, how many deaths, at what age, and all that. And the additional part of that is the verbal autopsy, where the death, we actually go and do a detailed interview trying to establish the most probable cause of death. And the reason we do that is for our study shows that only 42% of people die in any kind of health facility. And it's not always usual to have a death certificate. So even if you wanted to use medical records, you wouldn't be able to establish what's the cause of death in this population. And the other, I would say, rituals. When somebody dies, for instance, they are buried with all their documents. So sometimes even when you want to, even if a death certificate was issued, you wouldn't get it. So we do these detailed interviews with either the next of kin or the caretaker or the nearest, the person that has an understanding of the circumstances of death. And then we give this interview to some physicians independently, and they read it and say, okay, the most probable cause of death was, tuberculosis, or this was a maternal death, or this child died of pneumonia. And, there are established ways of how to, deal with these things. So out of that, we come up with cause of death profiles. So some of the data comes from, this demographic surveillance system. But then, in addition, the second data source, we looked at the women who gave birth within a certain period, and we asked them, where did you give birth? And they gave us a list of health facilities. And then we went to those health facilities to try to establish what kind of services are offered, what are the staffing levels, what kind of equipment do they have, and what quality of care do women get when they actually go there. And one of the surprising things was the women gave us a list of about 40 health facilities. But when we went to them, only 25 of them actually offered delivery care, though the women said they delivered there. And only 15 claimed that they only do antenatal care, they don't deliver, because perhaps they thought that there would be some penalties with, offering delivery services in the kind of establishments that they had. So the data is based on only those 25 that admitted or said that they were offering delivery services. And then, as I said, some analysis from the Kenya Demographic and Health Surveys from 1993 until the latest, which is 2008. So I'm looking at maternal health outcomes at different levels. I'm starting at contraceptive use. Somebody once stated that somebody who uses contraceptives and doesn't get pregnant is not at risk of an adverse maternal event. So I'm looking at contraceptive use as a maternal health outcome, but of course in a positive way. And then some of the consequences of non-use, teenage pregnancy. And then at intermediate outcomes, those that actually get pregnant, whether they use skilled antenatal care, whether they use delivery, skilled attendants during delivery. And then, of course, the ultimate outcome, which is maternal mortality. So I'm borrowing from the Kenya Demographic and Health Survey to look at the contraceptive prevalence rate. What we have done is to look at the national estimates, categorize them between rural and urban, and then look at the indicators of wealth and look at the poor among the urban. So the urban poor here is actually, a different level of analysis, trying to, as I said, urban poor, then urban rural, and then the poor among the urban population, which, one may question the wisdom of doing that. But we're trying to put across that it's something that we need to pay attention to, and maybe in subsequent surveys that perhaps pay more attention to how the sampling is done to be able to do these kinds of analysis. Because, as Anthony said, just saying urban does not really say much, because there's so much heterogeneity within urban areas. But one of the things that we are showing here is, in terms of contraceptive prevalence, the red line is looking at the urban poor. They've actually done very well because they've caught up with the urban average. So that's one of the only positive indicators of maternal health in this whole analysis. So by 1993, the urban poor were doing worse even than the rural, but now they've actually overtaken the rural, which is at around 38%, and they are up to 45%. But the general picture of contraceptive prevalence is, nothing much has really changed in Kenya since 1993, from around 28% to, just below the 40s. But not much has been going on since 1993, despite a lot of things that have been going on, but also being aware that, especially, from the late 90s and part of the early 2000s, there were, substantial reductions in funding for family planning programs. Total fertility rate, the urban poor are here in the middle. So we find that the compared to the whole of Kenya, they are doing better. Compared to the urban poor, the rural areas are doing better. But then compared to the urban general, they're doing much worse. So that would mean that if you took the estimates for the urban rich, then they would be probably, somewhere either the low twos or the high ones. Actually, our research shows that the wealthiest within this area where we work, their total fertility rate is around 1.8, while the poor is around 4. So they're still, even within the slum setting, is borne out by here, there are those differences. Teenage pregnancy. This is one where I deliberately added the urban rich. Almost 4 times as many teenagers were pregnant in 1993. And the rich have sort of gone up a bit, but nothing much has changed for the urban poor. So 26% of teenagers among the urban poor are either pregnant or have had a baby. In our demographic surveillance system, this is about 30%. 30% of 18 and 19-year-olds have either had a baby or are pregnant. So, as I said, one may question the wisdom of doing this analysis, but it's not showing us much that is different from what we know by focusing on these demographic surveillance sites where we're doing our research. So, antenatal attendance with skilled attendant. As I said, this was information that we got from women who delivered within a certain period of time. And we asked them whether they had sought care. So this was self-reported. And we find that they're not doing badly. Almost 90-something% of women have actually used antenatal care. And it's not very different also for delivery, but there's a caveat, because women said, "Oh, we did seek care with this skilled attendant," and some of them are those where we went and they said, "No, we don't offer delivery care." So possibly because there was no qualified staff for that. So there's a caveat about this. About 70% of women that actually say that they sought care with assistance of a health professional. Antenatal care timing. So people say, "Oh, we did go for antenatal care while we were pregnant," but when you look at when did people start actually going, so we are comparing the women who delivered in the slums with the data from the DHS for urban Kenya and for rural Kenya, and we find that only 7.5% of slum women had their first visit within the first trimester, and this is compared to 17% for the whole of the average for urban Kenya and 11% for rural Kenya. So even with that, in that respect, the slum women are doing slightly worse off than the women the rural average. The frequency, only 54% of slum women had at least more than 4 antenatal visits, compared to 71% for urban Kenya and 54% in rural Kenya. So in terms of that, the slums are doing just as well as the poor, or just as badly, maybe I should say. Now, this is the ultimate, as I said, the maternal mortality. And we deliberately did the delayed maternal mortality estimate because we think that this without doing that, you ignore certain realities that are associated with especially things like AIDS in women that give birth. So these are estimates from the Demographic and Health Survey for the whole of Kenya. As I said, 418, it's gone up to 488. And this is based on the demographic surveillance system, 709. So in terms of, this could be maybe possibly better compared with the 418. So at this point, I don't know, almost 80% higher in terms of the maternal mortality ratio. Of course, there were issues with the numbers. The numbers were quite small, so the confidence intervals were very wide, but still they were not near the 408 and 414. Now, we looked at the women who gave birth and then died within 1 year of giving birth, and that's what came up to 954. So we think that this is something that maybe should be done more often, because for women that, for instance, have HIV positive, when they have a baby, the death may not occur immediately after, within the 6 weeks. And ignoring that sort of ignores the reality that we know is associated with the progression of the disease once somebody gets pregnant and has a baby. So this is just something that's out there that perhaps should be done more often. But the key message is just the disparity between the 709 within this demographic surveillance site and the 414 for the whole country. So we went further, looked at these women and tried to establish, as I said, we have other women that have delivered in the slum. So all the women that delivered in the slum were interviewed. And then we compared those who actually died, the late maternal death, and those who had other pregnancy outcomes, that was a live birth or the woman was alive, and tried to see where did they deliver, who delivered them. And you can see only 1 in 5 of the women who died were actually delivered by a health professional, compared to 2/3 of those that did not die or had a positive maternal health outcome. The same thing, where did they deliver? Almost 86% delivered outside the health facility among those who died. Almost 91% of those who had the late maternal death delivered outside the health facility, compared to 65% of those that did not have any adverse maternal health outcome. Abortion is a big problem, because among the women that had the maternal death, actually the majority of them died as a result of an abortion and its complications. And the interesting thing was that when you went to the health facilities and tried to find out the most common causes of death, abortion was not even listed among the top 5. And it's not surprising, because if you combine this with that, most of these women are not even having the abortion within the health facility, they're having it elsewhere. Place of death, also a bit interesting. They did not deliver in the health facility, but they died in the health facility. So, something else to look at. 14% did not seek care. Because I said we do this verbal autopsy, so it's a whole detailed history of the circumstances around the death. So we can tell those who sought care and those who did not. So 14% of these women that had a maternal death did not seek care. And part of it could be related to, the commonest cause, which is abortion. In Kenya, abortion was illegal until a new constitution was promulgated last year. And now there's still questions about whether it's legal or not, because different people interpret the constitution differently. But we've not had a case where we've sought somebody to interpret the constitution about that. But somehow the policy, the law has changed slightly, but still there are questions about, what that means. Beyond the numbers, as I said, evidently we found that many women say they used skilled healthcare workers for antenatal care. There is a high use of skilled attendant at delivery, but the definition of skilled is questionable. And also when they say that they go to health facility, what's a health facility is questionable. The quality of easily accessible health facility is very poor. There's a near absence of the public sector. As Tony said, the informality is part of the definition of what constitutes a slum settlement. So informality means that no self-respecting government can put a formal health facility within an informal settlement. And we are told that we've not seen the maps, that some of the big maps, the grand plans for Nairobi, for instance, where some of the slums exist are like high-speed train stations and others are forests, reserves. But people have been there since the 70s. But on the plans, they don't exist. They're not there. They are just either high-speed train tracks, or they are high voltage power lines, or pipelines to take oil from the port to somewhere else, but there are no human settlements. So there's no way a government can put a health facility on top of what should be a future train station, for instance. So there's a near absence of the public sector. We've done a survey that looked at the health facilities, not only in these two slums where we are doing the demographic surveillance, but we added the famous Kibera slum. And we enumerated 503 health facilities, and out of those, only 6 were public. Not within the slums, within a kilometer, a 1 kilometer radius of the slum and within the slums. Only 6 out of 503 were public. And of course, there's a prolific private sector where there's a vacuum, people will always feel it. So the private sector is very prolific. But of course, there are other barriers. When people talk about the skilled attendant, this was in the same survey. So the health facilities that people told us that they had babies in, we went and tried to enumerate how many health workers were there and tried to categorize them. And out of the about 550 health workers that were enumerated, only 16% were doctors, 5% were obstetricians, and about 4% were registered midwives. So these are the people that ideally would be considered to be skilled attendants within this setting. And the majority, community nurses, and other categories. So when people say that we had a skilled attendant, it raises the question, what does that mean? Is it that anybody that was putting on a uniform or a white coat is skilled? The second is still on the same point. We enumerated the 25 maternity health facilities that they told us. We excluded 4 hospitals. This is the National Referral Hospital, Kenyatta. This is like the regional maternity center, the biggest maternity center perhaps in Africa or East Africa. And then other district hospitals. So among the 21 non-hospital facilities, only 4 had an obstetrician, 8 had any kind of doctor. Some did not have a qualified, not even a nurse. 7 did not have piped water in the facility or the compound. And 7 did not have infection control guidelines. But these were places that people actually delivered. And I believe this maybe was one of them. Maternity is right there. They actually offer maternity services in this place. They even do circumcision, which is interesting. But the quality of private services vary widely. These are all facilities that actually in the slums. So this is the famous one down there, but there's something that's, reasonably not so terrible. And there's one that's reasonably good. So all these do exist. And this is most likely a private not-for-profit, either faith-based or NGO that's running this. This is probably a mix of the two, but probably maybe a small local NGO, and this is probably an individual that decided to set up shop and offer services. But there are other barriers. Cost is an issue, and one of the slums, as a result of our work, was one of is one of the slums where a pilot was done for this output-based aid voucher scheme. And for the uninitiated, this means that women buy a voucher at about $3, and it entitles them to free antenatal care and free delivery care, and family planning for long term. If you want to maybe tubal ligation or an IUD inserted, you could get it free, and also for gender-based violence services. So this $3 voucher entitles you to all that, and the person that offers these services gets reimbursed by somebody, and they're getting reimbursed up to, I would say, $40 for maybe a delivery, or for C-section maybe up to $200. So there's a very high uptake. Almost 88% of the women that got pregnant bought this voucher. So that means that in the absence of cost, perhaps more women would go to more, I would say, high quality or appropriate health services for their delivery and antenatal care. Transport is an issue. The population density, our estimates put it at around 60,000 per kilometer squared. People living in, like skin to skin, literally. Very poor road infrastructure, and this is the quote from some of the focus groups we've done with the women. One woman stated that from here one has to go to Kenyatta or Pumwani. Kenyatta, as I said, is the National Referral Hospital, and Pumwani is the big maternity center. And we really don't have money to take us there. If you get complications late in the night, traveling from here to Pumwani is far and risky. There are many thugs on the way. The road is bad, and there's no way you can get a vehicle to come this far in the community to carry your patient. If only there would be good facilities at Makadara. Makadara is a health center that's within maybe a kilometer or so from the facility. At least it is a bit nearer, but still not near enough. The facilities there are not enough, and after 2 hours without delivering, they'll still take you to Pumwani, and that's an expense to you and your families or friends. So if somebody, if there was a need for an ambulance, there's simply no way the ambulance could go anywhere because there's no road. The structures are right next to each other. Insecurity, as already alluded to up there, we have thugs at night along the way. Both women and men fear, and it's hard for them to come out and assist. Most deliveries at night happen in the homes instead because of these reasons. So it's actually like, among the women who bought these vouchers, about 18% of them did not use it. And this was one of the main reasons. If you get into labor at night, you wait until morning. If you're not delivered, that's when you go to hospital. Otherwise, you'd have to wait it out or deliver at home. And of course, there are other issues, poor attitudes of healthcare providers. When people go, they're abused because they're poor, they don't have money. Some are arrested if they don't have money to clear the hospital bills. So if you get that experience, maybe you'll never go back to a healthcare facility. So some thoughts on what could be done. Our belief is that without supporting the private sector, I think it will be a pipe dream to address the maternal health challenges within these informal settlements. It will possibly never happen that governments are going to put in place enough health facilities to cater for these women and children in these settings. The private sector is already there. As I said, 496, 98 out of 503, they are there. And I said there's a whole range of them. So without support of the private sector, they are doing it their way, the way they know. Part of the survey that we did in these health facilities, we looked at the training needs assessment of the staff that were in these facilities. And we found that while in the public sector, people had been trained and trained and trained and trained to the point of, death, I should say. Almost 70% of the women, of the health workers in the private sector, the last training they had was the formal training before they got out of college or university. No single opportunity for any training. There are new guidelines that come along all the time, but the opportunities for this training in the private sector is almost non-existent. And yet, perhaps they are the ones offering the majority of the services for the women. Of course, issues of equipment and infrastructure, supplies, supervision, but more importantly, regulation. our survey still shows that almost 40% of them have no kind of document that shows that they should be operating. No license, no registration with the, whether it's the NGO board or the Ministry of Social Services, nothing. As I said, some of the facilities, they don't have a qualified, any kind of qualified health care worker, but they're still offering delivery services. So if the health service regulatory environment was improved, perhaps some of these private providers would come up and they would be offering services that are, you know, very high standard. And those that are not, maybe would go out of business. We're not saying that we should close them, but if there were a few good ones offering real high quality services, maybe the ones that are not would go out of business. The local health service governance structures, I think, need to be improved. The issues we talked about training. Some of the discussions we've had with the local health managers, for instance, would tell us, oh, you know, we don't control the training. The partners just come. If they have money, they will train. We can't tell them not to train. Because if they don't train, then our healthcare workers will be demotivated, because training is, I think, supplementary income for some of them. It's not that people are training because they need the skills. They do need some skills, but then they're getting, I think, too many skills and no time to implement what they've been trained in. And there's no system to regulate that. Who gets training, when, how long, how often, and what happens after the training. Actually, that's a big issue. So strengthening the local health services, the governance structures, perhaps would address some of these issues. And of course, issues of insecurity. As we said, security is a big problem, that if you get into labor at night, you know, you'd better stay at home or else. I was supposed to say something about policy and action. And I don't have a slide on that. I'll just give you our experience. I think the first start is to have it as a philosophy. Our philosophy is that we don't do research for the sake of research. So it's ingrained in us that we need to use the research, you know, we need to produce research, but use it beyond ourselves and our papers and our CVs. So I think it's a start that as an institution, it's part of our, I think, belief and value that we need to use the research beyond knowledge generation. And we have a fully fledged policy engagement and communication department. We've concentrated a lot on communication for the last maybe 3 or 4 years, and now we are going more into the engagement part of this unit. And part of what we do, I mean, we have a very nice website, I'm told, those that have visited it. So the website is one way that we communicate. We produce, we package the evidence in a way that is palatable to diverse audiences, to the media, to the community. I'm told it's time, so this is my last slide. One more minute, please. And but in terms of policy engagement, our belief is that it's not only the parliamentarians that, you know, sit down and write policies. There are also decision makers that are not actually parliamentarians. So we're working with both the high-level policy makers, but also the ones that make the day-to-day changes or actions that actually maybe later become policy. So we have very strong links with ministries. When we're doing our research, we involve them. Sometimes, not all the time, at the design stage. By the time the results are out there, you know, knocking on our door, we want the results. And depending on how interesting the results are, sometimes it's just natural. And we have had very successful policy to action research, but others where, you know, for 3 years you're still knocking on people's doors and nothing is happening. So I think maybe I'll address some of the issues around policy engagement during the question and answer. Thank you.
Thank you, Catherine. I'm sure we'll get to the policy issues during the discussion. I'd like to, maybe Luke, if you could come up and give your remarks, then we'll have time for some general discussion.
I will try to be short. Let's say thank you for this invitation and the pleasure that to be here. As UNFP, I think we are proud to be partnershiping with the Wilson Center and with the Maternal Health Task Force, not the MHTF, which is another thing, but the Maternal Health Task Force. And so I am happy to participate, and also I am very humble because I think we have listened to very excellent presentation going into details. And I would say that in my part, I have like Tony said, enjoy the preparation of something about the topic. And I was going through some literature and reports and to refresh myself about what is already well known about that. And so I think I would like to take a little time to discuss my own modest experience, but also perhaps to come back to some important things that we have to have in mind anyway, that probably we know already. And with your permission, I will make some quotes. And when I was looking for how to start, like Tony, I decided to start with, and we don't discuss that before, I decided to start with poverty because, in fact, all the things that we are talking about today are so related to poverty that it's not a health issue per se, it's really largely beyond that. And as I'm belonging to UNFPA role is also to measure. And as Tony mentioned, we have yearly reports, and the 2007 report was about urbanization. And I think it's still extremely valid. And when I read that, I think probably, even if I am not an expert on population, I thought that many things were extremely valid. So, and also Tony talked about census, and there are all the ways that UNFPA, out of the health sector itself, are trying to participate in this debate and also to build the data that we need to act. So poverty, just to remind that more than 1.4 billion of the population of the earth today is under $1.25 per day. And it is estimated that this will grow. And in addition to this 1.4, we have 2 billion, which are very close to that. So immediately when we talk about poverty, MDG 1, we are facing an enormous challenge in terms of size. And if I refer to some recent USAID papers, this will increase due to, in relation to the recent crisis, by 64 million additional extreme poor will come or are coming. And why urbanization and poverty? Because in 2007, it was the purpose of this report, the urban population became more important than the rural population in the world. So addressing the issue of urbanization and poverty and slum, and I really support what you said about the difficulty of definition of this type of concept, we are, I think, addressing one of the most important issues. And when I heard from the two previous speakers, I have the feeling that we know a lot about poverty, and probably we know that we are missing the massive investment that government and the international community should make to address poverty seriously. And this also needs a continuum of action. We cannot reduce poverty because we will invest during 2 years. We have really to change the way we are working, we are implementing the things. So the long term is important. But at the same time that we need massive investment and massive programs to address that, I think we need to go to the details and to go to the individuals. And I think your presentation both were very interesting for that, because we cannot address poverty like general things that you just solve because you put money in. If you don't go to the details of even knowing the individuals, I think you cannot achieve something which is sustainable. And this immediately led me to the fact that for poverty reduction and working in the urban areas and the poor, the importance of the communities and the NGOs is clearly even more important than for the rural areas, I think. So this is my feeling about what I just heard. UN Habitats, which is the UN organization we are referring to in general for this type of problem, estimates that globally, approximately 1/3 of the world's urban inhabitants lived in urban slum condition in 2005. Of these, more than half are in Asia. Nearly 2/3 of city dwellers in sub-Saharan Africa live in a slum or something like this. And the proportion of urban dwellers living in slums is particularly high in countries such as Ethiopia, Angola, Central African Republic, Chad, Guinea-Bissau, Madagascar, Mozambique, Niger, Sierra Leone, Sudan, and Kenya. And we know that the different patterns that you talk about, total exclusion or partial exclusion and different models, are very important if we want to analyze. And as it has been said very eloquently before, not all the poor are living in slums, but also not all inhabitants of the slums are poor. So we are here really in a complex issue, and we come back to what I was trying to say, that we need to address that very, very carefully. The impact of urban setting on health, and in particular inequity in health, has been largely developed and published and documented. We have evidence to show that while on average public services, including health and health service provision in urban areas, may be better than in rural areas, these averages often mask wide disparity between more and less disadvantaged population. So one key factor, and this has been said already, is the exclusion of the marginalized and vulnerable in public health planning and responses. And we are part of this, so I think it's certainly something that we need to address. When I was looking at the different documents, you are pushed to go back a little more on the past, and I cannot resist to the fact that the Alma-Ata conference addressed already very clearly the need to act to implement health for all. And when we are talking for all, we are talking about the poor and the urban poor and the rural poor. And the gaps, the evidence shows that the gaps between rich and poor countries and between the rich and the poor within countries have since increased. Also, an important document I was referring to, and I will refer more than one time, is a report in 2005 of the Commission on Social Determinants of Health, which has been established by WHO. And this report has really also informed us and called for action. Unfortunately, I'm not sure that we are taking very, very seriously all the conclusions of this report. When we are talking about inequity in health, the definition given by this report, final report 2008 and not 5, sorry, the definition is as follows: where systematic differences in health are judged to be avoidable by reasonable action, they are quite simply unfair. It is this that we label health inequity, and the Commission had, putting right these inequities, the huge and remediable differences in health between and within countries, is a matter of social justice. And I think this is exactly what we are talking. I will not come back to the need of measuring, because I think you have been extremely, what you have said was extremely good. Just to say that the tools that we are using are not appropriate very often to distinguish between the poor and the rich. And when in maternal health, for example, we are conducting emergency obstetric care needs assessment, we see that in rural areas, there is no access to health. In Ethiopia, 3% of the health centers are equipped to produce emergency obstetric care, basic emergency obstetric care. It's better in the urban areas. But if we use this type of need assessment for urban areas, this don't give us too many enough information to address. So we need to have specific tools. And what are the specific tools? And in my readings, I was interested to see that WHO has developed a tool for urban settings, which is named the WHO HEART tool. that you know certainly. And I was also interested to see how the different coefficients to measure inequalities have been used. And it's extremely important to see that it is very often related to the security issue. And because we know that big discrepancies between poor and rich are matter of possible explosion. And if we think about what happened in the Arab world at the time, we know that this is led by the urban young people, educated but poor because no capacity, no opportunities for employment, no opportunity for really have a normal life. And this is what we consider. And this is, if we use this type of coefficient, and the more known is the Gini coefficient, we see particularly in Africa that South Africa is really a country where the inequities are massive, even in the urban settings. And we have, following South Africa, Namibia, Mozambique with Maputo, and then we arrive to Nairobi. So we are here in issues which are extremely important. And by the way, as it is a security issue, the hope is that the world will address that seriously, and perhaps not because it's a health issue or women issue, but because it's a security issue, perhaps the poverty will be finally addressed seriously. We know all the consequences of health inequities, and I'm sure I have nothing to teach you on this issue. We know that the high levels of inequality do not just hamper poverty reduction and economic growth, but they all impact on aspects of human development. Health indicators, and I don't come back to that, you gave an excellent examples. All the issue of water and sanitation, you address also that. The issue of promiscuity, lack of space, and all the violence against women, but violence in general, insecurity related to that is extremely detrimental for this population. And the mental health is a very severe issue in poor urban areas. The dismantlement of families, the migration, the poverty, as all factors which are so heavy in the shoulders of this population. Unemployment, I talked about that, the lack of opportunities for job, the psychological consequences, and the political possible repercussions. So we know that it's a very important issue. So when we look at this type of documents that I mentioned before, we have, I would say, global strategies that they try to design and to promote. And one in this report, the WHO report on social determinant for health, they have enumerated three strategies. First of all, targeting disadvantaged population groups or social class, which is obvious. You need to target the poor if you want to solve the problem of poverty. Narrowing the health gap. This is a more difficult and very political, I think, issue, because here we are going to gender, we are going to women empowerment, we are going to a number of issues which are extremely important, but probably more difficult to explain, to analyze, and to promote. And the third strategy is about reducing inequities through the whole population. Because as it has been mentioned also, we cannot say that the poor are here and only here. The poverty is something which is very streamed, I don't know how to say that, distributed among the population. And based on that, they propose also a number of responses. Incorporate health in urban planning and development. Clear. Emphasize and strengthen the role of urban primary healthcare. Primary healthcare. So we come back to Alma-Ata. Strengthen the health equity focus in urban settings. Health equity. So we need to address the poor. Put health equity higher on the agenda of local governments. Decentralization, local government, working close to the communities. and pursue a national agenda on this issue. And interestingly, again a quote, and pardon me for that, but I think it's interesting. The report in 2008 takes the central policy importance given to economic growth. Economic growth is without question important, particularly for poor countries, as it gives the opportunity to provide resources to invest in improvement of the lives of their population. But growth by itself, without appropriate social policies to ensure reasonable fairness in the way its benefits are distributed, brings little benefit to health equity. So the growth, the economic growth, will not per se solve the problem, and without additional programs targeting the real issues of poverty, we will not probably move. Now, what to say about sexual reproductive health issues? Because is there something very particular in urban settings compared to other settings? I will be very brief. My first point would be about adolescents, because it's probably here also the main issue that we have to tackle, not only in urban settings, but in urban settings particularly, because due to poverty, the migration of adolescents and young people is certainly more important than the other part of the population. So we have to face, and we have many examples, and I will not here be able to describe all what we can read in the literature and know when we are visiting the field about all what a million of NGOs, very innovative, very inventive, are trying to put in place for adolescents and for addressing many other issues of poverty and particularly sexual reproductive health. So we know that, and I was struck in reading the literature that, do we know that in the urban areas, when we do an average on the world, quite half of the adolescents are living without any parent. And if you add to that, that 20% live without the father, you arrive to situations where effectively you have to be innovative, because how to address adolescent health without, a framework which we are used to think about, and we have to be totally out of the box, I would say, and invent new ways of addressing that. Early marriage, out of school, in school, all these issues, I have no time to develop, but I think it's all the issues that we are talking. The second topic, I would say, is violence against women. Violence, but violence against women, gender-based violence, is one of the most, I think, striking issue when we are talking about poverty, particularly in the urban settings. Girls' protection, where the girls can be protected. In many places in the world, girls cannot be protected. He wants to cut. I will stop immediately. Family planning. Family planning, unmet needs. Unmet needs are still extremely important in urban areas where the family planning services are very close. So the issue is not only to provide services, the issue again is to go and work with the communities. I have no time to go. I will close on a conclusion. Corruption, civil conflicts, misguided policies, lack of follow-up, and insufficient aid are among factors which explains failures of anti-poverty programs. But there is growing agreement that many programs failed because they did not effectively engage the people they were trying to help. I close on that, I'm sorry. Thank you.
Thank you, Luc. We haven't really talked much really about urban areas. We've talked about rights and justice, certain population groups, a lot about poverty, a lot about inequality. But I think we get back to a fundamental question maybe that Tony raised early on. He said, are urban populations critical for our achievement of our maternal health goals? And I think maybe with that we could open the discussion, and we welcome comments from a public who's been very patient. Mary Ellen.
Well, first of all, thank you all for very, very interesting and enlightening presentation. I have a question that I think it's
Oh, yeah. And maybe you could identify who you are and then make the
Marilyn
question.
Stanton, USAID. Thank you all for the excellent presentations. A question for Catherine. As you talk about and have mapped the urban environments, I wonder if your techniques that you described or others help us identify people in these areas who are leaders, who are influentials. We think when we go to rural areas, we go to the village chief or the imam or something. Who in these areas can we work with in order to tackle some of the problems that all three of you mentioned?
We'll take two other questions, and then do we have other questions or comments? Here we are, up front.
Hi, I'm Beth Outerson. I'm at Save the Children, and I work in the adolescent reproductive health programs there. And I have a quick question about the comment about adolescents, actually, because, you know, we know that there are large groups of young people, as you said. Some may be educated, some may not be coming into urban areas. And if they don't have a parent or some kind of protective unit that's providing, you know, support, emotional, physical, everything. You know, in many of the countries that we work with, we see gangs as providing that kind of support, and we know that can be a very negative influence on the life and the community of that young person. So I was wondering if you had any program ideas about alternatives, because we have a world where, you know, one or both parents are going off to other countries for employment. So this is going to be a growing problem. There's not going to be any kind of a, enabling environment for that young person.
Take a third question, comment? Yes? Please identify yourself and...
I'm Roger Mark D'Souza with Population Action International, and I have two quick questions. The first, I was intrigued with Catherine's point that when you look at the urban poor, that overall they're doing better than the country overall, and they're doing better than the rural poor, but they're not doing better than the urban population overall. And I find that very often when we get into discussions with policy advisors or funders, and they're thinking about where they could leverage their funding, and they're looking at urban centers, questions around economies of scale come up for urban settings. And when they look at rural populations and where they could provide funding or support, they're very interested in those areas because they're able to access populations that traditionally they may not be able to access. So how do you weigh that, this question of economies of scale in an urban setting versus investing in rural settings where funders may be able to reach populations that normally they could not reach? So that's my first question. My second question is, last week I was presenting on a panel on food security at the Aspen Institute and looking at population and reproductive health dimensions as part of that question. And a Latin Americanist asked a question about urbanization in Latin America, and particularly urbanizing coasts. Many of the coastlines now are increasingly urban. Do you find that the set of issues that you are raising differ for urban coasts? When you think of questions around food security, spread of HIV/AIDS in coastal areas of high migration or high mobility, or questions around food security. So what's your take when you think of urban coastlines and whether that changes the parameters at all?
Great. I think we'll go Catherine and then Luke, and then Tony can take the last question.
The first question on who is influential in these areas is a very interesting one. One would expect that the same structures, for instance, that you have in rural areas, the village chiefs, the chairman, or that they would be the influential ones. They are the ones that have influence, but it's not all the time positive. Our experience has been that they are mostly gatekeepers, and the first consideration is what is in it, for them. So I wouldn't say that they've been most helpful in instances where we've wanted to engage with the community. And we find that perhaps the churches and the church leaders and the imams may be more influential in their own way and perhaps in a positive way. We have experiences with the slum upgrading programs that are going on in these communities, and it's a constant battle trying to deal with the village chairmen and the chiefs. And but there are other groups. There are women groups, there are youth groups. So in most cases, it's actually better to go directly with these small groups that are already established and are there, and they will get things done. But going through the chief and chairman, it's courtesy. We do it for courtesy, but not that we expect much to come out of it. Yeah. The issue about the urban poor, I think what I presented is that the urban poor are not doing better than the urban average. They are somehow in the middle of the rural and the urban average. So they're not doing better than the urban average. In some respects, they're doing better than the rural, but in some respects, they're doing worse. And in terms of what would be the advantage, for instance, in trying to address issues of the urban poor, I don't know about the issue of economies of scale. If it's to do with numbers, I think I wouldn't look at it in terms of, I would look at it in terms of the investment per capita you would need. I don't know whether that captures it. Okay. We're talking about a situation where you have 60,000 people in 1 kilometer square. So you don't even need like 10 different health facilities to reach 60,000 people. You need maybe just one, and everybody would be within 1 kilometer of that health facility. So that's the advantage you're looking at, that these are people, very many people in very, very small geographical areas. So investments, you wouldn't need as much investment as you would need to reach the same population if you went to a rural area. That's the argument we make. So not everybody seems to buy it, obviously, but I think it's a good argument that with this very high density, you have many advantages, that with minimal investments, you can reach many more people. About the urban coastline, I don't think I have much to say about that. I don't have much experience with that. I would expect that, the issues with this rapid population mobility and urbanization and urban growth, I think some of the issues may be cross-cutting and they may be the same wherever you go. Within these slums, we have two different kinds of settlements. We have the more long-term settled places where people have been there since the 70s. And the majority have been there for an average of 10, 15 years. And then you have maybe a small percentage that comes and goes. And then we have these settlements where it's like a mill, like people are getting churned in and out of this, slum. So in those, the issues are different in both slums. The first one, very difficult with social cohesion. People don't even know the person that is right next to them. When you talk about community, when you talk about leaders, people have they don't have the same sense of community because people are there for 3 months, 6 months, 1 year, at the maximum maybe 3 years. So I think with these urban slums that are growing along the coast, maybe the same issues would be there, depending on the dynamics within and the drivers of this growth. But beyond that, I don't think I can add much.
Good. Thank you. Luke, you want to comment on the family issues?
Yes, thank you for this question. My comment, I have no solution, but my comment would be that the response is probably necessarily integrated. We cannot take one aspect of the problem of the adolescent. We need to offer something which be able to support adolescents in all the dimensions. We have some good examples. One which is coming to my mind is one example in Addis Ababa, where we have, with NGOs, open centers for training for girls and young women. And this is to give them vocational training at the beginning. But in fact, the things is larger than that. Many are offering a room, a place to live, because protection, as I was talking about. Many also, and it's also an opportunity to address many other things, and particularly health education, sexual reproductive health, family planning, protection, HIV, etc. So there is a package each time that we are looking at what are doing the good NGOs on this topic. So I would say that integration, and we can use an entry door to respond, but at the end, we need to provide a package if we want to really support the young and adolescent. This will be my comment. It should be, yeah.
Tony, you want to take on the first question from our gentleman from the Caribbean?
Yeah, I think I could comment, I think, on all the questions briefly. I guess I'm most interested in Mary Ellen's question about community structures within urban communities. This has been a big focus of the direction and interest of urban programming of late, trying to promote, I guess, sort of equivalent community groups within urban populations, and because they probably have been under-supported by traditional development programs in the past. You look at any developing country and the number of NGOs that operate within urban areas versus outside ones, and you'll see a big difference in terms of population per group sort of measure. And so groups like Slum Dwellers International has grown up as an international network of community-based groups that focus on these populations and organizing them to represent themselves in discussions with local governments. And although these groups don't exist in many places, and actually where they do exist probably means that, as Catherine was saying, the community is less vulnerable to begin with. It's those communities where social networks are very weak that are typically the most vulnerable ones. And so it's difficult coming in. The most vulnerable populations are ones where there is no real leadership, and it's very difficult to operate within them. But as Catherine was saying, recognizing that it's almost the opposite of rural areas. Traditional leadership oftentimes are the owners of exclusivity. National politicians are tribal leaders from cities where their land is worth a lot of money and they're very rich people. And they are the slumlords rather than the sort of nice chief that you go to and get introduced to the women in the community by. But I would say that although NGOs will be very important trying to express civil society through these sorts of groupings, I continue to harp on the importance of decentralization, which was mentioned by Luc, and is extremely important. Urban populations and the challenges of dealing with them highlights the importance of it's all about the local in solving these problems. They're very unique. Each city, Mombasa is different from Nairobi in terms of its challenges, coastal versus highland, the ethnic nature, the economic makeup, and so forth. Local governments need to be empowered by their national governments to tackle these problems themselves. And NGOs can only do so much. It's the mayor, it's the city councils that need to recognize these areas as important and put their political stake into solving them. That really is what's going to lead to long-term change. What I often remark on is in many slum communities, community health workers, if they do exist, can be the only government official that communities see, ever. Other than an occasional politician who will come through looking for votes. They are extremely important. I think the health infrastructure has a big responsibility in encouraging those actors to be responsive to local government. Health ministries are notoriously adverse to decentralization, but I think they, especially in dealing with urban challenges, they need to get behind it and support it. To the extent that they can. Well, the youth bulge and the youth challenge in cities, again, extremely important, and we'll suggest some of the different social structures that you can key into. The reason that many youth are in urban areas is because of economic activities. In places like Ghana, for example, associations of hairdressers and other trade-related businesses are very strong and very youth-orientated. And plugging into them is often a very productive way to work. Church groups are others as well. In terms of economies of scale, I think what Roger Mark was talking about in terms of maybe something that was getting better was, say, contraceptive uptake within the urban poor. I would just guess, without any backup, other than knowing that social marketing has really taken off in Kenya. It's been quite effective with a variety of products. And where you get economies of scale, where you often see the most effective results from social marketing is within urban communities that are market orientated. When you're trying to market a product like condoms or a water quality improvement product, it's people that use money every day and have access to stores that are going to be responsive to that sort of approach. And I would bet that has been a big reason for that uptick in the urban poor, increasing their contraceptive use in Kenya. Just one last comment about urban coasts. When I think of coastal communities, they tend to be somewhat outward looking in terms of their importance typically with trade, and there are sort of pluses and minuses to that. Oftentimes there are areas that are a bit more dynamic, less conservative. A lot of more progressive governments tend to grow up in coastal cities, I think you'll see in many countries, but they often have a lot of challenges of low-skilled labor markets associated with fishing and port facilities, which draw a lot of unskilled labor. Some of the pictures from Tema, which is the big port city in Ghana, where I've spent some time in slums right next to the port there. It's fishermen and port workers, and not a lot of highly educated people in those situations. And that's, I think, a fairly typical profile of a lot of urban coastal areas. And I think it sort of oftentimes sets up a difficulty of differentiation within the nation. I know Ecuador's coastal communities, there's a lot of African American influence there, former slave. So there's a racial divide between the highlands and the lowlands there. And that ethnic divide is oftentimes a very important dynamic within this exclusion within urban areas. Many of the slums, sort of well-known slums in Africa, are actually oftentimes Islamic outposts, because in Christian majority countries in much of sub-Saharan Africa, they're sort of forced into exclusion and tend to group together. Korogoncho is a fairly heavily Islamic orientated community, and there are many in Accra as well. And again, having local governments recognize these barriers and making special efforts to reach out to them, inclusion of them, is probably the big take-home message in terms of approach and things that we're trying to promote. Inequality by itself, this was pointed out to me by some Wilson Center colleagues, in terms of what has been seen to lead to conflict within urban areas. And I know conflict, I was just at a security-related, I end with that because Luke brought it up in terms of a link for motivation of health. We constantly, our DOD, Department of Defense folks, that's their area of interest. I was just talking to some of their intelligence people on this. But this insecurity comes not from necessarily inequality and looking at the gaps, Gini coefficient sort of measures of income inequality, but it's where that's combined with exclusion, where poor people feel that they are disempowered. And that's what you see in terms of many communities, slum communities that become fiery, is because they feel that they're not represented. Nobody is listening to them. It's not that they're poor, they recognize that and they accept that, they're working through it. But if they're being ignored, if they're being abused by the police, if they don't feel that they're recognized at all, that's what leads to problems. And that's what leads to the barriers for people not accessing government health facilities and not engaging in the process of finding solutions with their government. So that's the importance, again, of local government, because it will always be local government that will be most answerable to people. It's not going to be the president. They need to see somebody close that is concerned about their issues. And I would say that's the thing that we increasingly need to promote, is that local government responsiveness.
Thank you, Tony. One of the remarkable things I think about Catherine's presentation also was the dynamic role of the private sector and the use of potential vouchers, which actually give money to the poorest people, and they make the decision about where to use that, and that's a way of empowering. I think it's 5 o'clock now. Hyder had one. Do you have a final question or comment, brief, so we could close?
Yes, it was a comment and also a request. Thank you. I mean, all the issues that you raised related to urban slum areas and the health status, it goes beyond one approach. We need to review whole development issues. And that's a nightmare, because for many years, we never debate on the development issues. We try to look at each sector and try to come up with a patching, how it can be fixed and how it can continue. Now we are at a stage that we cannot do that anymore unless we look at the whole total picture, starting from family planning down to the governance. That is the spectrum. Now here is the request. We used to have an annual global conference, Population and Development. Population Council used to take lead. UNFPA and USAID used to cooperate. Whatever the reasons, we did not have that after 1994. So may I request that since UNFPA and USAID are on the same platform and Population Council is chairing, can we get back to that population development issues and look at all the issues once again and come up with a comprehensive approach globally?
Thank you, Hyder. We'll take that as an aspirational recommendation. With that, I'd like to thank the panelists, Catherine, Tony, and Luke, for a great presentation, set of presentations, and a nice discussion. Thank you very much.